different types of cancer. In the lungs, there could be so many cancers. The breast has got different types of cancer. So our job is not to say what type it is, because that's the specialist role. Our job is to say, it doesn't look right. Let's do something about it. We want to start with the very first sign before it begins to spread. And Laura is right. We find that ethnic minority groups tend to present very late. We don't know why. So it's good that she's created this awareness for us to start to think, let's do something about it sooner. So we're looking at the signs. We want to know the symptoms. Symptoms are when those things start. How do we know they have started, and what should we do about it? And then we talked about risk factors. So these are those conditions that put us at higher risk of getting cancer. So yes, we talked about the different types of cancers. It is a lot easier. I wouldn't say cancer is curable, but it can be curable, because I do have patients who are 10, 20 years since their cancer diagnosis and they've had no symptoms. I do have patients who were treated in 1996. We still do follow-up and they've had no problem whatsoever because they picked it up early. We're talking about early diagnosis and treatment. If I ask us, does anybody know anyone, a friend or a family member who has been affected by any type of cancer? Please remember, if you have a friend or a family member that has been affected by cancer, quite a lot of us, more than half of us know it. So it does affect a lot of people. We know that as we grow older, cancer, age is a risk of having cancer. As we grow older, the cells have been there for some time. They have been exposed to so many things and have that tendency to start to act in a different way from their different neighbors. And yes, cancer affects people in different ways, different people with different symptoms. But like we said, what we are trying to talk about is how to identify on your own body, because you now know your body so well. When you see something abnormal, you're able to say, that hasn't been there before. And you watch it. 2 weeks, 3 weeks, it's still there. No, I'm going to get an appointment and have this checked. Some people come to me and say, Doctor, this is not just have a look. And I keep saying, if it changes, come back. If you notice another change, come back. That's our job, to pick these things early. So don't ever get tired, even if it means you're waiting to get, I know NHS GP appointment, difficult to get. I'm still trying to get my own appointment with GP. We have more patients than we do have doctors. So don't worry if you're waiting for an appointment. Get that appointment and be checked. Thank you. So I'm going to start with breast cancer. It is the most popular cancer in the UK, and most people affected by breast cancer are actually women. 96% of them, 96% of breast cancers are women, really. But it is the most common type of cancer. Now, age plays a factor in this. Like we said, the older we are, the more at risk of having cancer. And we do know that there is some form of genetic, so it can run in family. Cancers can run in family. If you are a believer, believe in God, whatever faith you have, people would say, I'll pray, I'll remove that cause from my family line. We are with you 100% in that. But please still also look out for any abnormality. So the sort of things that we look at, our genetic makeup, we can't do anything about that. Where we are from, we cannot do anything about us. If you're from Africa, you're from Africa. Even if you were born in the UK and all your descendants, you still have that lineage. It doesn't leave your gene. But there are some things that we can do something about. We know that obesity, if your weight is higher than normal, you are at risk of so many different types of cancers. And we'll talk about some of them today. Being diabetic also predisposes us to cancer. And then if we are a bit on the busty side, that can also predispose us to cancer for so many reasons. One, the type of breast tissue. Two, it is quite difficult to examine the breast properly if if we are a bit on the busted side. So that's something to look out for. Alcohol, smoking, these are all risk of different types of cancers. And then hormones. So like I said, I'm a menopause specialist. So we do know that HRT, the contraceptive pill, if you started your period very early, and if your period carried on and ended late, all of this puts us at risk of cancer. So the word I'm using is at risk. You're at higher risk. That doesn't mean you will have it, but if you're able to identify that, okay, because of my weight, because of my family history, I know my grandmother had cancer, my aunt had, that means I need to be aware of this. I need to be able to look out for this. The most common symptom of breast cancer is a lump. And then the next is pain. The guideline on breast pain is if you have any breast pain that persists for more than 6 weeks and you have tried your usual pain relief, it's not going away, please see a doctor. The reason we say more than 6 weeks is with our hormones, with our change each month, our period and everything, we can have a bit of breast pain, but that should resolve. Now, if that pain is not resolving, you do need to see a doctor. I'll go through the examination of the breast. And please, excuse me if you see me doing, like I said, I'm a women's health specialist. And when mothers come to me with their daughters, one of the things I always say is, do you know how to examine your breast? I haven't seen a teenager that has said this. And so I show them. I'm very happy we have a lot of young girls coming in, because it's very, very important. I'm a mother of 2 girls, and they know how to examine their breast. There are certain things we cannot do anything about. Our ethnicity, our genes, our breast makeup, that we cannot do anything about. But we can pick up these things early. And if you know how to examine your breast every month, we advise, once you start having your period as a lady, once you have your period, you're a lady. I always tell the young girls when they come, even they are 12, 13, and I say, young lady, they smile. I said, the moment you start having a period, you're now a lady. So you need to know how to look after your body. You need to know how to look after your breast. 2 days after your period ends, examine your breast in the bathroom, looking in the mirror. And if you do that every month for the rest of your life, the moment an abnormality appears on your breast, you will know. You will look and say, no, there's something wrong. I have seen women come to me with mass just sticking out. In fact, on their clothing, I can see the mass. And they tell you, well, they didn't know on time. And I'm wondering, how didn't you know on time? Because they weren't examining their breast regularly. Some will have a patch, black patch, melanoma. They wouldn't have known. You cannot be shy of your body. Nobody will look after your body but you. So you need to look and examine, and anything that does not make sense, see your doctor. Next slide. Thank you. So this is breast examination. There are different ways of examining the breast, but most importantly, stand in front of the mirror before or after a shower, so you should be undressed. Make sure you are looking at the mirror. And then you go round the breast with the palm of your hand. You feel, it's supposed to feel soft. The best way to imagine, if you have water blown in a balloon, that is what your breast should feel. Sorry, you see me pressing this. I do this all the time. So I'm used to explaining and examining because I don't want them to miss it. So press with the palm, with the ball part. Press, go round in a circular manner. And then do this. The other thing you need to do, sorry, I'll drop this mic. Like I told you, I'm not used to using, is to feel your armpits. And that's because the blood flow from our breast goes to the armpits. So the blood flow goes this way. If there's any funny thing going on the breast, it will drag that infection to the armpits. So sometimes breast cancer is not picked with lump in the breast, it's actually picked with a lump in the armpits. So if you have a lump in your armpits, see a doctor. It could just be a boil, and we just need to give you antibiotics. But it could be the beginning of something. Like we said, there are things we cannot do anything about. That's fine. We leave it up to any super being up there. But the things we can do something about, let us do. That's breast examination. Oh, God bless you. Okay, thank you. Yeah. So, breast examination, you start with, you look in the mirror, look at both breasts. They look okay, so pick one. Just rub your hand round, or you can do upwards, down, as long as you go through everything and then feel for that armpit. Then you go to the next one. You check that as well. You do that 2 days after your period every month. When you get used to doing that, the moment you feel, what is that? That wasn't there last month. Okay, let me watch it. 2, 3 days, 1 week, it's still there. That needs to be picked up. Because something about breast cancer, once that abnormal cell starts misbehaving, like we said, you have that cell, for example, Laura, and it's already misbehaving, it starts talking to the other cells. Before you know it, it spreads to the lymph node. Like we said, the blood flow goes that way. Before you know it, it starts involving other structures. But if you pick it up early, just that lump, or maybe just the breast can be removed. And like I said, I have so many patients. They've had breast cancer. Some of them have had mastectomy. Some did not need mastectomy. They are fine. They come for checkup. When they see anything, oh, Dr. Baba, please just check this thing. We check, it's fine. And they are absolutely fine. But most of, they are Caucasians, to be honest. I don't have any ethnic minority who they usually present late. There's no reason to present late, really. It's just to be aware of all these things. Thank you. Next thing, cancer of the neck of the womb. I've used cervix there because we talk about the cervical screening. That's why I've used the medical term. But we're talking about the neck of the womb. There's a diagram after this that I'll use to explain the different parts. This is a little bit different from the breast cancer in the sense that this is picked up in younger age women. And because over the years, they found out that it's picked up in younger age women, they've started the vaccination, the HPV vaccine. We'll talk about that in a minute. So what happens with the neck of the womb? Like we said, abnormal cell appears and starts misbehaving, starts communicating with the other cells around the neck of the womb and starts spreading. HPV virus is one of the notorious, in fact, majority of cervical cancer are caused by that. It's an infection that the body should be able to clear. For some reason, in some people, maybe because of their increased risk factor, they are not able to clear that infection. It goes on to causing cancer. It's more common in women. It's more associated with STI, so it is a sexually transmitted infection. Yeah? And of course, smoking, like we said, almost all cancer, you will see smoking is the inside as a risk factor. And because this cancer is around the neck of the womb, usually that individual will complain of problem during intercourse when they are being intimate with their partner, either bleeding or pain there. Now, we know about the vaccine, the HPV vaccine that is given to our 12 and 13-year-old. And there is some form of myth amongst our people. When I say our people, I'm talking about we ethnic minority. You know, where they say, if my child has this vaccine, they become more promiscuous. I have no idea where that came from. But let's look at it this way. Like I said, I'm a mother of 2 daughters. I have no idea who they will marry. The people they will marry, I have no idea where they are coming from and what they've done. But I'm protecting my daughter. And that's the way to think about it. It has nothing to do with promiscuity. One day our children will get married and we don't know who they are marrying. We don't know that person's background. You need to protect your child. When your children are having their BCG vaccine for tuberculosis or their other vaccine, polio vaccine and everything, you don't say, my child will never meet anyone with polio, so I don't want them to have the polio vaccine. Or my child will not meet anyone with tuberculosis, I don't want them to have. You don't say that. So how do you know who your child will marry? How do you know who they will meet? They have nothing to lose, but a lot to gain by having the vaccine. Okay? And then we have our cervical screening. Again, our ethnic minority, we don't like having the cervical screening. I have no idea why. So I work in the Tameside area where we have a lot of our ethnic minority, and majority of them don't want to. They say, oh, I feel uncomfortable someone going there. You know, I don't like anybody going down this way. But the truth is, the bitter truth, if that person ends up with cervical cancer, not only will the surgeon go there, the anesthetic go there, the oncologist, it will be a meeting point. They will be having MDT meeting over that place. So which is better? A practice nurse with her small plastic tube just doing that. And the moment you leave, she doesn't even remember that you've even been there. You know, as part of my role, I do a lot of coil and a lot of women coming with bleeding problem. I investigate a lot of that. And sometimes they will say, oh, doctor, I'm so shy. If you do this for me, will I look at your face? And I tell her, I say, look, if you know the exams that I took to get this degree, when I'm looking down there, I'm trying to make a diagnosis. I'm not even seeing your face. I am trying to make sure that this thing is okay. Am I doing, you know, I'm thinking of what I learned and putting that into practice. And when I'm done from there, I'm trying to process everything and make sure you are safe. So thinking, Maria's face looked like this, or Laura's face looked like that. When any of you who's a mom or has had babies, when you're in labor, when the thing hits you, you bother who is in the room. So when we start saying, I don't want to come for my smear because, you know, the nurse will look at me. Please don't forget, it is real and it happens to young women. And the reason it happens is, for some reason, maybe they feel they're younger and they're shy and, you know, this life, we're here only once. I'm not sure. I don't know anyone yet who will tell me they came before and have come back again and there's a scientific proof of reincarnation. Until then, we've only got this time that we've got. So if that will help us, please get our teenagers, go for the vaccine. Once you're turning 25, go for your smear. The next 3 years, just keep checking, you know, keep checking. And like we said, there are certain things we cannot do anything about. But things that we can do, please, let's go ahead. Thank you. Next slide. Next thing is the cancer of the womb. Now, this form of cancer is actually seen in the older age group. So we're talking about the post-menopause age, you know, after 50 sort of thing. So anybody with a womb is at risk of this form of cancer, to be honest. Again, this sort of cancer, hormones play a role. The reason is there's the hormone that makes us female, the estrogen. It's a good hormone. It helps with all our menopausal symptoms. And so that's why when it's being withdrawn around menopause time, women have hot flushes and everything. But it can be notorious with the way it plays about on our womb. So that is what makes us at risk of cancer of the womb. So HRT, and this condition, polycystic ovarian syndrome, is a condition where the follicles in our ovaries produce more of the hormone. And so the woman is at risk of cancer. Menstrual history, again, if you had your period very early, maybe 10, 11, and then your period isn't stopping till after 50, that's almost 40 years of estrogen in your body that predisposes to womb cancer. So like we said, there are certain things we cannot do anything about those ones, but things that we can do about. If you have an abnormal period, so let's talk about our period. I always say to our young girls, and even when the women come to see me in their 20s, I ask them, tell me your menstrual cycle when they come with a problem. Tell me what your menstrual cycle is like, because all our periods will be different. I have a sister, her period is different from mine, and ours were different from our mom. So only you knows what your normal is. And they'll tell you, oh, I don't know. They don't know their menstrual cycle. We must have calendar somewhere, either on our phone or somewhere. Circle when you start and circle when you stop. Do that every month. There should be a pattern to it. You know, some women will say it's 24 days between my periods. And you're counting from the first day of your period to the first day of the next period. It's not the last day. Most women always remember when they stopped, but that's not what's important medically. Medically, it's when you start. If your period started today, the 31st, it stopped on the 6th. Next month, October, when is it starting? When is it stopping? Keep a track of that. And then when you notice there is an abnormality, if you have a smartphone these days, the smartphone will even tell you, it looks like your period is irregular. Smartphones are very funny these days. It will tell you, it's like an abnormality. Have you put in the right date? You know, so, but the beauty about that is you are picking up an abnormality and you are speaking to someone about it. Doctor, my period is irregular. There are some medical problems that are not cancer that can cause irregular period. That is true. But let us check. Like we say in medicine, we always look at the worst first. Let's rule out the worst. When we check it's not cancer, if we want to do an ultrasound, there are different scans we can do, but please speak to your doctor. The only way you can know that your period is abnormal is if you know you're normal. So please, all females, mothers, please teach your daughters to know what their normal period is. Thank you. And then ovarian cancer. This is even more, more rare than the other ones we've talked about. You don't see this commonly. But it does happen. And this is when the cells in the ovaries begin to act abnormally. Because the ovaries are seated deep inside our pelvis, it's not something you can see externally. It's not so unlike the other ones we've talked about, there is something externally that you pick on to know something has gone wrong. But with ovarian cancer, it's slightly different. So what people tend to come in with, they say they feel full, they feel bloated, you know, they've not eaten much, but they feel full, they feel as if there's wind trapped. Dr. Tola will know that in medicine, when we are thinking about ovarian cancer, we say 40, 50, fat, full, all the F with the female. You start to think this could be ovarian cancer. Again, the reason that woman is able to notice this bloating, this fullness, this pressure, she's thinking about her body. I know for us as women, as mothers, we get very busy. We get very busy with our children, with our life. I say to my friends sometimes, I'm a full-time doctor, I'm a full-time housewife, I'm a full-time mother. Sometimes there's no time for me. But really, you really need to know about your body. I'm feeling full. I've not really eaten. I'm not constipated. Why am I feeling full? There's a pressure in me, something that, it's not right. Let me go ask my GP what this could be, you know. And the person gets investigated, things are picked up early. So all of this is about being aware of your body, being able to look out for the signs, being able to pick up those symptoms and speaking to someone. Thank you. So yes, I was saying this is the diagram of the reproductive system of the female. So these are our ovaries. They look a bit forward, but they're a bit more backwards in our body. And then the womb and the neck of the womb, when we're talking about cancer of the cervical cancer, that's where that happens. Thank you. And then just two other cancers that are really, 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 really rare. We rarely see them. I think not so much in our ethnic group, more in Caucasian, but they can happen. And just to be aware about them. The vagina, sorry, please go back to the previous image. I just want to explain the difference in this. The vagina is like a passage from the outer part of the female to the neck of the womb. That's where we call the vagina. Thank you. Which is different from the vulva. The vulva is what you can see outside the female, you know, the folds there, talking about a baby. What you can see, that's the vulva. So with cancer of the vagina, abnormal bleeding. Again, the woman will only know it's abnormal if she knows what her normal is. It is seen in older women. One thing associated with both cancers is the HPV virus. Again, we are seeing this again. So again, we are seeing this virus that we can prevent and we can pick up early. Okay? Vulvar cancer, if there is any swelling, if there is any lump, if there is an ulcer not healing on the external part of the female, please see your GP. You know, make an appointment and have it checked. There are people who, I'm just getting a bit emotional. I haven't seen some people and they come in and they say, oh, there's been something there. I just thought it was nothing to worry about. And the moment you see that thing, even without being a histopathologist, even without being, I can almost say this is cancer because this person has waited and waited and waited. Again, if you know you're normal, if you look at yourself in the mirror before you go into the shower, look at your body. Anything that wasn't there before and is now there and it persists, please have it checked. Okay, so yes, that's the end of my interesting talk. Thank you. Thank you.
Oh, thank you so much, Barbara. That was, in fact, I wanted it to just carry on. I didn't want it to stop at all. I was enjoying that lecture. And like you said, our children, it's good that a lot of our teenagers are here today. We need to the awareness should start from, that, is it grassroots to call it now, or the youngest age you can think of. Once the girl starts seeing a period, she's a woman. She's already a woman, so we should have all this information. We're going to have to bring you back, Barbara. Definitely. We're bringing you back again for another session. Like that was very, very, very explosive. Yes, so have we got any questions for Dr. Barbara? So let's take some questions. Yeah, hold on. Let's pass the microphone to Remy.
Can vaginal warts become cancer?
So, if vaginal warts, are we talking, it's been diagnosed as what? It's been diagnosed as what? So it's unlikely for what to go on to become cancer if it's been diagnosed. But don't forget, the wart isn't supposed to be there. The presence of the wart may start to communicate to the adjacent cells and pass false information, and cancer can come about. So it's not impossible. It can happen, because we say when all the cells are normal, there's no cancer. The moment one of them starts to behave abnormally, it can start to pass false information. So on its own, no, but it is a predisposing factor, because as we know, what is an STI, we know that again predisposes to infection. Okay. Any other question?
Thank you. Any other question? Ask all your questions now. Don't be shy. There's no shy in when it comes to, or if you want to write it down, then you can write it down and I can read it out. Lizzie has got some pen and paper. So any other question? No? Okay. Let's give another round of applause for Dr. Barbara Ogidingbe. Yeah. Thank you so much for that. So I'm going to introduce our second speaker. He's going to come and talk to us about other forms of cancers. His slides are explosive again, and I can't wait to see what he's going to be delivering to us now. So Dr. Tola Omotosho is going to be speaking to us now. Thank you, Dr. Tola.
So, with the references, everything we got from there was on the Cancer Research UK. Everything is on the NHS website. There's nothing I have put there that was my own. I basically, the only thing that was mine is the drama I presented. All the information is from NHS websites. If you want to share that to them and from the cancer, because if you go on the Cancer Research website, it has the list of cancer, and if you click on each one, it gives you more information about it. So Laura can, share if you want to put the link there, so you can go all the information there. You even see that was where I picked those things from.
Thank you.
Okay.
Yes.
Okay. Thank you very much, and thank you for having me. Please, if for any reason you can't hear me and you need me to speak louder, let me know. Like Barbara said, I'm also a GP. We're not very familiar with the use of microphone, because everything we do is within a room, and even when we're discussing in a group meeting, we're not often so many. But if you do need me to say anything or repeat or speak louder, kindly let me know. I'm based in Altrincham, still in Manchester, south of Manchester area. And Barbara's been emphasizing some things about if you see something that is not normal, please check it out. Just like Laura said also, irrespective of the challenges and all that you may face, we do have this mandate as ourselves or as an individual that even though the doctor, the nurse have responsibility, the onus is also on us as individuals, but we see things that are not normal for us to check it out. Even if the GP appointment might be difficult. Someone or one of my patients once said jokingly that, doctor, it's very easy to get an appointment with God than getting an appointment with the GP, because all you need is Anyway, you're communicating, kneeling down and all that, and you have a direct access. But GP, it could be challenging. But despite that, there's a saying that take care of your body. That's the only place you have to live, which I found truthful. So whatever it's going to take for you to take care of your body, do not hesitate. And part of the thing that Cancer Care Diaspora is doing is, spotting the diagnosis, or let me say, spotting the symptom earlier, and you seeking advice about it. So prevention is better than cure, we do say. It's not just an old adage, it's still something for the future. Next slide, please. So I'll proceed with the signs and the symptoms. Now, this time I'll be talking about the general, as well as some that might be specific to some areas of the body. Human beings were quite a complex being. And like mentioned earlier, we have over 200 types of cancer as identified by Cancer Research UK. Now, some of the symptoms that individuals might have that could be general, in which some people might not even know what's going on. First, let's be aware that many of those symptoms, they're often due to things that are less serious than cancer. So, just to ensure that we don't over-panic or worry about, like mentioned earlier, you notice anything different from usual? Check it out, especially if it's persistent. So general symptoms that we could find at times include persistent, heavy night sweats or fever. So, and that's when it's not explainable. Nothing suggestive of an infection, no medication, but this is persistent. Please check it out with your GP. If there is an unexplained weight loss, so now that you're going to the gym, keeping a diet or things like that, and the weight is just dropping and you can't really explain it, get in touch with your GP to check that out. Tiredness that's more than usual, not related to maybe overexerting yourself or things like that, check that out with your GP also. That could be your body telling you something is not right. Now, unexplained bleeding or bruising from any part of the body except menstrual period. So including bleeding from the gum, bleeding into the skin, bleeding from the back passage. By the back passage, I mean where we pass the feces. Anything like that, check with your GP. If there's unexplained pain, this comes into play when we're talking about things happening in the bone, especially the cancer of the bones. When you start having or noticing pain in the individual, then we're to check that out also. Unusual lump and swelling in the body. So we talk about lumps and bumps, which are not expected to be there. Then in such a case, please check that out with the GP. And if there's a new mole or changes in the mole, by that I mean changes in the skin. So you notice anything changing or something different from usual, persisting, please don't hesitate to check with your GP. Things like pictures, family pictures, general pictures, even selfies, they come into play on such occasion. And apart from we as individuals having that responsibility, as colleagues, as friends, as spouses, we're also to keep an eye on each other. Be your brother or sister's keeper, so we'll say. So you notice something different. Oh, you look different from usual. You look lean. Oh, no, I didn't see this the last time I saw you. Oh, look at our picture. That wasn't there. How come? Have you checked it out? Those are also things that we can take into consideration. Now, when there are skin or nail changes or wounds that is persisting without an explainable reason, it is something that requires a medical attention also. Next slide, please. Now, going to some specific areas. Now, bearing in mind, this is not all over, but focusing on some areas. Well, there's anything going on in the mouth, difficulty with swallowing or food getting stuck in the throat, that could be part of the way the body is telling us. You need to check that out. Now, if there is any ulcer, and by that, that's a loss of the surface, either on the tongue or in the mouth, and if that's persisting longer than 3 weeks, it's something you need to get checked out either with your GP or with the dentist. When it comes to that of the abdomen, changes like bloating sensation, feeling of fullness, even with little meals, those are telltale signs of possibly a cancer going on. Heartburn, that's like having a burning sensation, especially in the middle of the chest area, feeling nauseous or like sick, and it's not it's not improving with every measure, either diet or medication given by your GP, then it's something you need checking out also. Whenever there's weight loss or appetite loss in the individual, that could also be a telltale sign of abdominal cancer. Now, the throat, changes in the voice, except if the person is like an opera singer or a chorister singing at the top of their voice, then we can say, okay, maybe there might be some straining at that moment. But in the absence of an explainable reason, croaky voice, voice hoarseness, persisting, it needs checking out. Next slide, please. This is a beautiful description on the Cancer Research UK website, just showing the different regions of the body where particular symptoms could be a presentation of cancer. And we can see, now, having mentioned all this doesn't mean, well, if someone is breathless, that's cancer. No. Okay, but it is a possibility of cancer. And also noting that I did mention persistent, unexplainable. So if the person is having things suggestive of a chest infection, straightforward chest infection, and the voice is hoarse, 1 week, 2 weeks, no concerns. But if there is no chest infection, voice hoarseness is persistent, the person is not being going to what? Britain's Got Talent or anywhere singing, then you need to check that out, okay? So voice hoarseness, coughing that is persistent, especially when there is blood stain in it. Difficulty swallowing, breathlessness, heartburn and indigestion, like we mentioned earlier, changes in the size of the breast, like Barbara mentioned earlier, bloating sensation, appetite loss, or any change in the bowel habit. We'll talk more about that soon. Blood in the poo or in the pee, and problem with passing urine. But the overall is, if you spot anything that is not normal for you, don't hesitate to check out and don't ignore it. Now, that has not listed all other things, and that's why that caveat is there. Whether it's listed here or not, because it's not mentioned anything about things suggestive of the brain, of the eyes, or things like that. So anything you notice that is not normal or usual for you, please check it out. Next slide, please. So we're coning down to specific cancers now. Bowel cancer, the signs and symptoms. As we mentioned earlier, they could present with any of these. Change in bowel habit, and by that it means feeling constipated or having loose bowel, which is not the usual pattern for the individual. It is worth checking out. Not necessarily that it is cancer, but you want to be sure. If it is cancer, you don't want to miss it. Bloating sensation, blood in the poo, unexpected weight loss, pain or lump in the abdomen, tiredness more than usual, and breathlessness. All those could present as bowel cancer symptoms. Next, please. So main thing, keep an eye on whatever is not normal for you. Next slide, please. Now, there are risk factors like mentioned earlier. We don't know what causes the cancer, but something puts some people at a higher risk. Now, with the risk factors, there are the ones we're in control of. What we're in control of, that's the one we are to monitor. The ones we can't change, then we stay with it. Risk factors when it comes to bowel cancer, eating too much of red or processed meat. Now, according to Cancer Research UK, 13% of bowel cancer actually links to this. So processed meat, preserved, processed in one way or the other, they have that tendency of increasing the risk of individual developing bowel cancer. Eating too little of fiber, so veg, fruits, they also contribute to that. Overweight or obesity, it's known to contribute to up to 13 types of cancer. Breast cancer, like mentioned earlier, including bowel cancer, that also could be a result of overweight. Low physical activity. So someone that is not exercising, we do talk about the 6 pillars of lifestyle medicine. Exercising or physical activity is one of it. So whatever we are doing, we do have busy schedules, especially the ladies, yeah. Mothers, wife, daughter, friend, professional, and all that. We should still create time. And any exercise, anything that we can do to give an exertion, that does help. So if we want to go to the shop rather than driving, we can just take a walk. If we have the dishwasher at home. If you want to, we can, but a little bit of washing. And ladies, you can even get the gentlemen in the house to do that. That will help us also to do a bit of washing or do a bit of, hoovering. Yes. So, and when we tell children to do that also as a form of a routine, especially on weekends, to say, okay, you got to take care of your room, hoover the floor, you hoover the middle floor, someone does anywhere else. It's also part of physical activities or exercises, which on the ultimate term helps to reduce that risk factor. Smoking tobacco, 7% of bowel cancer is linked to this. Smoking has no benefit on its own. Yes, some may say, well, emotionally they feel stable and all that, but when you compare or compare the outcome of the risk it puts on almost every part of the body, it's a cancer of almost anywhere in the body that is linked to smoking. Next slide, please. So alcohol, study does show that there is no specific safe drinking. Yeah, there is an acceptable one that's been recommended, but it's not on its own beneficial. Okay, so alcohol, 6% of bowel cancer is linked to this. The age, unfortunately, we can't do anything regarding that. So age is also associated with it. 40%, according to Cancer Research UK, are diagnosed at age 75 and above. Now, family history, unfortunately also, that cannot be adjusted. So if there is a family history of cancer, any cancer especially, it can also put the individual at the risk of bowel cancer. And that's important for us to be aware of our family history. So when we're registering at the GP surgeries, let's always put those details, because then that will be picked up by the system and needful assessment, including the screening, can be put in place. Ulcerative colitis and Crohn's disease. Apologies for those medical jargons. They just mean what we call inflammation in the bowel. The specialists are the ones that make that diagnosis. So if an individual has that, they're also at the higher risk of bowel cancer. And cancer of anywhere else in the body puts an individual at the risk of bowel cancer. Next slide, please. So further risk factors, medical conditions like gallstones or diabetes, acromegaly, which has to do with hormones in the body, that if there are benign polyps, polyps are just excessive growth or outgrowth in the lining of the bowel in this case. Radiation, being exposed to radiation, can also put an individual at the higher risk of bowel cancer. And that's why when you go for an x-ray, everyone goes out whenever the radiation is to be shot to take the picture. Infections, including what we call the Helicobacter pylori, which are part of the bugs that can cause excess acid in an individual. Thank you. Next slide, please. So the system is already in place to actually safeguard and help us in identifying whenever there is anything that puts us at the risk of bowel cancer. So there's a bowel cancer screening, and the aim of that is, as mentioned, is to pick it quite early or pick any changes that might likely change to cancer so that an appropriate treatment can be put in place. Now, the screening program takes place every 2 years the moment an individual hits the qualification or eligibility target. So, and that test is called the FIT test. Okay, and that's done in the stool to check if there is blood in the stool, because those are one of the telltale signs whenever an individual is developing bowel cancer. Unfortunately, it might not be so obvious, so you might not see it as a bright red blood, but a tiny bit of blood can be picked up by the system. Now, the eligibility are just be registered with the GP, and by the time you clock that age, the system will trigger the screening, and you just get a sort of a package to be delivered at home. Now, the age at which that eligibility is met varies from one region to the other. So England, where we are, it's between age 60 and 74. So by around age 60, or not far from having clocked 60, you should get that package. If it's not been received, then you should get in touch with your GP or contact what we call the National Screening Team, and they will be able to send that to you. Now, for some other people at the higher risk, that those that have maybe a family history, they could be sent those packages much more earlier because there is a higher risk for them. Next slide, please. Will it be possible to play that? Yeah, if you just copy it onto, or maybe onto another web browser. This is just a demonstration of how we are expected to take the sample whenever we get the package sent to us. And that does help in actually picking up any blood cells in the stool, which the system can use in analyzing and checking the risk of this being a bowel cancer. And then the action can be taken regarding that. Okay. It's quite simple. It comes with its own instruction. The leaflet is folded in it, and it will come with a container, and it will have like a stepwise guide on that. Okay. So if we're in the UK, we expect that to be coming in around age 60. However, the age range is gradually being drawn lower. And that's because of the incidence of what's happening at the moment. You know, we see many people having it even before having the cancer of the bowel before age 60. So we don't want to wait till when they're 60 before the screening is put in place for them. So it's gradually reducing, especially in England. In other parts of the UK, it's still maintaining the same age range. Now, the upper limit in England is 74 years. So if anyone still wants the screening done after Okay, we're still trying to get that in place. Just a short video of how the sample is taken. So I'll say main lesson from this is, yep, since we know the age cutoff, if we receive, fine, we go home with it. If we don't, then let's chase it up with our GP. And usually the results for that come out about 2 weeks after the sample is taken. And depending on the result, further action can be taken if it's going to be just repeat it in 2 years, or if there's going to be a need for further investigation by which the person will now be signposted to where things like what we call the camera is done to further examine the individual. By that time, it's already getting to the specialist stage, but action is taken based on the result of that stool sample. And it's just more of whenever we receive it, please don't ignore it. Okay? Of course, it is voluntary and left to the individual, but since we know it's our home body, it's actually to take care of our health, then we should take that responsibility of action in it. Okay. Okay, thank you very much for that. There we go.
When it's time to do your bowel cancer screening test, you'll get a kit through the post. It can spot the early signs of bowel cancer and it saves lives. In the kit, there's a small stick which is used to collect a sample of poo. The lab checks for any traces of blood in the poo, which is sometimes a sign of cancer. On the day you do the test, write the date on the tube. Check your letter for full instructions on how to label the tube. To take the sample, you'll need to put a plastic tub and a few layers of toilet paper into the toilet to catch the poo. And then you just do your business. Then, using the stick from the kit, scrape a bit of poo onto the end of the stick, making sure the 2 holes are covered. Put the stick back into the tube and twist it to close. The tube goes into the envelope provided and into the post. Be sure to send it back as soon as possible and you'll get the results back within 2 weeks. If there's any trace of blood detected, it could be a number of things, not just the early signs of bowel cancer. The letter will explain the results and if you need to do anything next. For more information about bowel cancer screening, go to cruk.org/bowel-screening.
Thank you. Next slide, please. My apologies, I didn't give any warning about anyone eating before doing that, but it's all part of the business. Yeah. Okay. So that's it with the bowel. And okay, next one is the prostate cancer. Thank you very much. Prostate cancer, of course, that's only relevant in men, is found to be like the 3rd commonest cancer in the UK, and is the leading cause of cancer in the UK amongst men. And like the name implies, it's expected to be found in men. Now, that's a pictorial diagram of where the prostate is found. It's more in the pelvic region, we'll say, and it's the size of a walnut. It's just at the base of the bladder, and we can see what looks like a funnel there from the bladder. That's the pathway for the urine to come out. So, if anything is going on in the prostate, it can narrow down that funnel, causing problem with passing urine. Luckily, the ladies don't have any worries with that, but it's mainly in men. Okay, so that's the appearance of where the prostate is expected to be. Next slide, please. So the signs and the symptoms of prostate cancer, unfortunately, it might have no symptom. And people, they do say many people die with prostate cancer rather than from it because it doesn't come with any symptom in there. By the time the symptoms are coming up in cases of prostate cancer, it would have been like an advanced stage, which unfortunately, it's commoner amongst our ethnicity because we don't know, or we ignore, or we have like a sort of a high pain threshold, so we don't pay attention to it on its advance. So back pain, bone pains, tiredness, feeling unwell in an individual, or when there is weight loss, unexplained weight loss, they could be the symptoms of prostate cancer. Next slide, please. Unfortunately, there is no national screening test for prostate cancer in the UK. Okay, and some reasons that have been posted for that is, first, that there's a blood test, though, that prostate-specific antigen blood test, which can be done and can be used as a sort of a diagnostic tool. But on its own, it's not very specific. So it could be high from exercising, from trauma, from water infection, which can cause unnecessary panic in an individual, coupled with it could be normal in the presence of a prostate cancer. So it's not, statistics has not shown that it's fully representative. And that's why there's no national screening for that. So, but the blood test can be done to diagnose and also to monitor. Okay. Now, the test can be done for any individual from around the age of 50. So by age of 50, you can just contact your GP, say you want to have it done, and depending on the results, action can be taken from there. If there are symptoms for which the individual wants to have the prostate-specific antigen done, then the GP might want to do what we call prostate examination also, in which a finger is placed at the back passage to feel the surface of the prostate. Because when the prostate cancer is about occurring, where it starts often is at the surface of the prostate, which, if it is occurring there, the individual, or let me say the GP, will be able to feel it and be able to escalate things further. Next slide, please. Now, that's the examination of the prostate. Now, 1 in 6 men in the UK will get this at some time. Okay, and it's, like I mentioned earlier, is the commonest cause of cancer amongst men in the UK. Next slide. Risk factors. The ages is between 75 to 79. Ethnicity, it's commoner amongst the black men and the white, but it's least or less among the Asian community. Now, genetics and family history, just like most other cancers, any family history of cancer in an individual puts the person at a higher risk of having it. So more especially if it's the first degree. By first degree, I mean dad or brother. When we say second degree, that's like uncle, cousin, things like that. It increases the risk in an individual. Lifestyle factors, that has to do with exercising, obesity, overweight, it also increases the risk of cancer in an individual. Next slide, please. Medical conditions. Lynch syndrome has to do with history of cancer of the bowel, which puts the individual at a higher risk of having prostatic cancer. For some reason, tall height in adulthood or heavy birth weight is also been identified as a cause of, or as a risk factors for prostate cancer. The hormones, so that has to do with irregularity or overproduction of some hormones in the individual, as well as exposure to pesticides, is being known as identifiable risk factors to prostate cancer. Next slide, please. And that's it with the prostate cancer. We go to the next one, which is the lung cancer. Part of the symptoms that we need to pay attention to are, as highlighted, persistent cough, shortness of breath, coughing up blood, feeling tired, having ache in the chest or in the shoulder. And that's because of some particular kind of lung cancer, which can contribute to shoulder pain. Please, if this is occurring and persisting, call for medical attention. Next slide, please. Other symptoms are, as highlighted, like every other cancer, loss of appetite, unexplained weight loss. Now, recurrent chest infection in an individual, if that is occurring also, then it's a sort of a red flag, we call it, something for which your clinician will need to start exploring any risk of cancer of the lungs. And if there are swelling in the fingers, we call it finger clubbing. That has to do with what is going on with circulation at the tips of the finger. If that is occurring, call for medical attention. Next slide, please. The risk factor, smoking. Smoking is always the main culprit there. Smoking, asbestos exposure, dust exposure with those chemicals, arsenic, nickel, and chromium. Coal exposure when exposed to the coal tar on the road, and chronic infection. So for people that have long-standing chronic infection of the lungs, if they're under the specialist will actually be looking out for that to make sure there is nothing else indicating a lung cancer. Then ionizing irradiation exposure. Next slide, please. For lung cancer also, there is no national screening program, but in some regions of the UK, mainly in England, really, we do have this lung health check, which is picked up by the system. This actually started in 2019 in England and Wales, and the target of that is to be able to pick up any early signs of lung cancer so that a successful treatment can be achieved. Now, the National Screening Committee, they have this one which is called the Targeted Lung Health Screening, also called Targeted Lung Cancer Screening. Next slide, please. And that talks more about it. The criteria for the individual to be invited for that is between age 55 and 75, the individual has to be registered with the GP so that their names and their history can be picked up on the system. And the person must have had a history of smoking either previously or currently. And the result is often received within 4 weeks. Usually it's a telephone call, then action will be taken depending on what the outcome of the questionnaire was while the telephone consultation took place. Next slide, please. Talking about cancer as a whole, how do we reduce the risk factor? Remember, we said we don't know the causes, but there are risk factors to the individual. Now, Cancer Research UK did say 4 out of 10, more than 40% of the cancer can be prevented. And that can be achieved by making healthy choices and healthy changes. Now, some of the risk factors, like we said, family history, the race, we're out of control of that. As highlighted earlier, breast cancer is now being found to be occurring among the younger age in the Black, African, and Caribbean descent. Now, the Black and minor ethnic group, unfortunately, we do have this lower awareness or lower uptake when it comes to things like information or screening. And that's the importance of what cancer care in diaspora is doing at the moment, to create that awareness so that we're not presenting at the last stage when minimal or no remedy can be put in place. Next slide, please. So let's look at those things. Avoiding smoking, not smoking at all. If it's not started, don't even try it. If it's started, call for medical attention with your GP to help stop it. Ensuring balanced diet, like we mentioned earlier, obesity and overweight contributes to a large number of cancers. Enjoying sun safely, and by that I mean whenever the sun is out, we all want some sunshine, and what we mainly need to do is just to protect the skin. So we talk about skin protective factor. Now, there's been that myth that some people feel, well, if you have a black skin, then you don't need the sun cream. We all do need it. Okay, the pigment in our skin just protects about 15% protection against the ultraviolet light. The SPF 30 gives about like 97%. There's another one, SPF 50, gives about 98% protection against the ultraviolet light. Even the SPF 100 gives 99% protection. So we all still do need it, okay? So we're supposed to be enjoying the sun safely. So skin protection, shades, that does help. Cut back on alcohol, physical activity, it does no one, no harm. Vaccination against different infections. So we have the HPV, like mentioned earlier, that will also prevent the risk of developing cancer at a later age. Attending the screening program. So like mentioned earlier, the cervical screening program, once we have it, details registered with the GP, the system will trigger it from age 25. you'll be having it. Then by age 50, it reduces, or it increases. So from age 25, you'll be getting the letter to have it every 5 years. From age 50, every 3 years for 25 to 50. From 50 to 60 or 64, you start doing it every 5 years. Thereafter, you now have to request if you want it done. For that of the breast, from age 50, you should start getting invitation for the mammogram. So if you're not getting all this by the time that it is due, please contact your GP. And for that of the bowel screening, like we mentioned earlier, from age 60, hopefully that's going to be drawn down to age 50 soon, in which you'll be invited. Whenever we're called for it, let's attend to it. Next slide. Just a bit about our balanced diet. Global thing as advised by the Cancer Research UK also. Yes, paying attention to that of the diet, especially with the fruits and vegetables. I do notice in our diet also, in our ethnic group, we have more of the beef, meat, anything much more like that rather than that of the vegetables and fruits. We do need all those because they contribute to the increase in the fibers we have in our diet, which puts us at a lower risk of having things like bowel cancer. So ensuring we have an estimate or a rough distribution of our diets that way helps also with our healthy meals. Next slide. We can now imagine what could have happened or what we can make happen in another 10 years. This was a sort of retrospective picture of what could have happened if in the last 10 years no one was smoking, we all had good weight, eating healthy, more active, all other factors. The end result is the number of people that will be diagnosed with cancer at the moment, as mentioned by the Cancer Research UK, an average of 1,000 per day. So 1,000 diagnoses per day of cancer. So we can imagine how much of that is going to be reduced if we're able to put these health measures in place. So making healthy changes can make a difference to the cancer risk in the future. Next slide. I think that should be some form of myth. So some people do think about, okay, the diet, burnt food, and things like that. I know in Nigeria, I know that we talk about jollof rice and all that, and they say the lower portion is the one that has all the nutrients. And so whoever loves that, well, that's like a green light that says, yes, burnt food are not known scientifically to be contributing to cancer. Mobile phones or stress in an individual, but the ones that have been proven are as pictorially described there by the Cancer Research UK for us. Thank you very much. I think that should be the last one. Thank you.
Amazing. Wow. Thank you so much, Dr. Tola. That was another explosive one. I told you guys, yeah. So thank you once again for that wonderful lecture. Have you got any questions for Dr. Tola? First of all, then we'll go visit Dr. Barbara's lecture again. Any questions? You can write them down. Lizzie has got some pen and paper. Yeah, go on, Chidi. Just try.
Thank you very much, Dr. Tola. In your course of talk, you said for prostate cancer, there is no sign. So in this case where there is no sign, what's your advice? Is there any type of test one should do? Or is there a certain age one will get before they do that test? Thank you.
Thank you very much, Chidi. Good question. Yes, that's the sad thing with it. No symptom that one could check for. Usually, though, by the time there are symptoms, like I said, it's often late. But common symptoms that people might have with that of the prostate is problem with passing urine. So either going to the toilet more frequently and feeling they've not completely emptied the bladder. Burning sensation can occur. Straining to pass urine can occur, and they could have dribbling. Now, all those don't necessarily mean prostate cancer. They just mean something going on with that lower portion of the bladder, which many a times in male will be the prostate. More commonly, it's often due to what we call benign prostatic enlargement, just enlargement of the prostate, but it could also be something related to prostate cancer. So in the absence of any symptom, like you've mentioned, if there is a family history, that could be a trigger point for one to say, I want to check this. Usually not known to be common under 40, but if there is a family history, Yes, you can ask your GP, especially 40 and above, to say, okay, I want to have my prostate checked or the blood test done. Over 50, black and minor ethnicity, it's recommended to always request it. And most GP surgeries now, they send a sort of a message to individual to just say, oh, okay, we realize you're this, there's a high risk of prostate cancer in black and minor ethnicity and over 50. So we recommend or we advise that you do this. So if one is 50, it's often advisable to get that checked out. So even in the absence of any symptom, we'll still say check it. You're welcome.
Thank you.
Yes,
You
please.
know, when men have these symptoms, like weeing frequently, and sometimes the doctor might say, you go to the doctor, this is an enlarged prostate. And can that be like fluid or whatever?
Oh, on this one,
It's enlarged,
oh, I'm so sorry. When it's enlarged, can that be?
the prostate is.
Oh, yeah, it can be. It can be, but many a times, it's often just enlargement of the prostate. As we mature, the prostate gets bigger also. So at some time, it could put a pressure on that funnel, on that picture, which is the pathway through which the urine has to pass through. So in such a case, the person might be straining to pass urine. Okay. As a paradox, though, the person might feel is empty the bladder becomes quite sensitive that a little bit of urine in the bladder will make the person want to go and pee. So peeing more frequently could also be a sign that something is going on with the prostate, but it might not be specifically prostate cancer. It could just be the enlargement. So we still say, get to see the GP, let them make the needful examination and give the diagnosis. So we wouldn't just assume that it's just enlarged prostate, get to see the GP to make that conclusion.
I've got many friends, men friends, who's got that, and then the doctor put them on something.
Finasteride or this,
Yeah,
okay, or tamsulosin, yes.
Yeah.
Yes, that's mainly for enlarged prostate. Now, by the time if there is any sign found when the GP does the examination or that blood test comes, the PSA we call it, if it's elevated, then the GP will escalate, the investigation further. So in such a case, if they've given them medication, that's mainly to help with the bladder neck so that they can be able to pass urine very well. That's fine, and they would have been able to rule out any possibility of it being cancer. But definitely, if it is something cancerous, they wouldn't just put on that medication. They will escalate it further. You're welcome.
Thanks, Magda. Yeah, any other questions for Dr. Tola or Dr. Barbara, our first speaker? Any questions? I have one here. I think it's probably for you, Barbara. It says, how many years after being free from cancer is safe to say cancer will not return? Because I know you mentioned something about that.
So first and foremost, it depends on the type of cancer. Some cancers, the oncologist will say after 5 years, if you're cancer, the term they use is cancer-free. Some cancer, the oncologist will say 10 years. Now, the truth of the matter, I don't think anyone can scientifically say cancer will not return. We do know that if someone has had cancer before, they are at high risk of getting cancer again. In fact, sometimes when people come in with cancer and we check their history, they had cancer many years ago. But yes, you are right. There are people who had cancer, was picked up early, they've had chemo, they've had surgery, they've been fine. So it's not like 1 + 1 is 2. No, it's very different because, like we said, there are risk factors. There are things that affect that individual's history, their family history, their weight. So you can't really say, if you've not had cancer after 10 years of having the first one, you will never have it. In medicine, we never say never, because we're not God, we're not the super being. But what we do is to look out for any abnormality. So unfortunately, I can't give a definite duration. It's just what it is. But yeah, sorry, I hope that helps.
Yeah, thank you, Barbara. Yeah, that should, yeah. But like you said, you can't say a definite answer. The people that have said, oh, 20 years, it's not had cancer, come back. But other cases, 5 years or within a year. So it's, but anything, like doctors have said, see your GP. Always, you're not bothering them. Just keep going back to see them. Thank you for that. So any more questions here, audio?
Why is breast cancer more common with Africa, black women?
So that's our ethnicity, unfortunately. So when we were talking, we said there are some things that we cannot do anything about. Unfortunately, it's our genetic makeup. You know, we are more at risk. It's like cancer of the skin. Caucasians are more at risk. It's just the ethnicity. It's one of the risk factors. You know, things like fibroids. Africans, we are more at risk. Africans and Asians is our genetic makeup. I don't know, maybe the super being shed certain things across the different parts of the world. We have no idea. But yeah, we know we are at risk of that. Yeah. Thank you.
Thank you, Barbara. Thank you for that. Okay, one more.
I have a question. Because someone in my church, he testified about cancer. She go through all the treatment and everything. But it's not even up to a year. We just lost her about 2 weeks ago. So it's not up to, because he said at least it will last up to 5 years or 10 years. But this lady, it didn't even last up to 1 year before she passed out, because she did breast cancer. So it now spread to the other one. But she go through the treatment and everything. She came to testify in the church. So suddenly we just lost her. It's not even up to a year. So.
Yeah, I'm sorry to hear that. And I think this goes to the question I answered earlier when someone said, what's the duration? The truth is we don't know. We do have some patients who 10, 20 years after breast cancer, in fact, I was speaking to someone recently and she had breast cancer in 1996. It hasn't come back since then. Other people, in fact, when Dr. Tola was talking about lung cancer, I remembered someone who had lung cancer in their early 20s, a non-smoker. And it just registered then that when the way it was picked up was recurrent chest infection. And that's another thing. I know some people say, I don't like my GP. You know, your GP is just a custodian of your record. And Dr. Tola explained that once you reach that age, it's triggered on the system. We are just a custodian of your record. If you re-register, all your record goes to that other person. We just look after it for you. So if you're not happy, you can always change. But the truth of the matter is that if you're unwell and you come to see them or you go to the out of hour 111, you go to A&E, it comes back to your record. And the reason it was picked up in this 20-year-old was that they were having recurrent chest infection. They were not asthmatic. They didn't have any chest problem. And the record clicked that this person is having, do a chest x-ray. And that was how cancer was picked up. Now, unfortunately for for us, sometimes we make very good agbo, which I'm saying, I don't say it's not work. And we get better because some of our medicines really are from herbs and processed and everything, or they get from antibiotics back home, it clears and this and that. But we are not being investigated properly, and it could be missed. By the time it becomes something, it's too advanced. Whereas if they had come first time infection, 3 weeks later, another infection, the system will pick it up. This is not normal. This person needs to be investigated. So yeah, we don't know why some of these things happen. Some people are at risk, but if you know the normal, the moment it becomes abnormal, we can pick it up. I said to Laura, I forgot to mention something. These days, we do have, whether we like it or not in our community, transgender is becoming quite popular. But the thing is, our birth gender, we are still at risk of that cancer associated with the birth gender. So for instance, a baby born female at birth that later on decides to be male, cuts off the breast tissue, it's taken off some, you can never clear off. They're still at risk of breast cancer. A baby born male at birth wants to become female, cuts off the genital to become, still has the prostate gland. So it's quite important that that birth gender, they should still have screening for it. They should still have. We do try and keep the birth gender on the record. I know there are a lot of political things about that, and they say people are not happy with it. But like we said, it triggers the system. If a baby born female at birth and changes to male, but that female is still on the record, when they are 3 months to their 25th birthday, the system will trigger and say, this is due a cervical smear. But if on the record we have changed it to male, we will never know. That's the only thing to think about. And so we try and educate people. And when people say, oh, I'm not happy, I'm no longer female, we agree with you. You are now male. But we will not be able to screen you and pick up any condition. We're only a custodian of the record. The moment you move to another GP, that's fine. But while you are with us, so that's just something to think of. I said I would mention. Thank you.
Thank you, Barbara. Thank you so much. Okay, one more. Dr. Onesi. Is it for your wife or for Dr.
No, I'd like to say thank you to both presenters. It's been a pleasure being here. I would, however, like to contribute. I'm a physician. With respect to questions that have been raised, people having treatment and giving testimonies, that's fine. Anyone who's had treatment for cancer after having a successful treatment should be on a surveillance program. And it is very important, irrespective of how we feel, to ensure we keep those the appointments. Some people stay on the surveillance program for 5 years, some people longer, depending on what grade or what type of cancer the individual has had. Over a particular period, your oncologist can say, oh, I think we are happy now. At this point, we can discharge you from the surveillance. Fantastic. The importance of the surveillance program is to pick recurrence early enough such that you can still benefit from some sort of treatment. So it is important we keep to such surveillance programs. The other issue I would like to raise is anyone who's developed one cancer is also at risk of developing another type of cancer. So we need to be at a high alert for that. The risk factors that both presenters have identified are correct. We have the modifiable risk factors and the risk factors we can do nothing about, the ones we cannot modify. Take-home message from this presentation is for us to look out for the risk factors we can do something about: smoking, alcohol, our weight, and improve on them. And the ones we can do nothing about, well, I still think we can do something about them.
Yeah.
Is to be on the lookout. That's what we can do so that we can identify them early enough and get good quality treatment. I'd like to say thank you to you, Laura, for putting this presentation together. Fantastic.
Thank you. Thank you, Dr. Onesi. Yes. Amazing. Okay. That's the husband of our Dr. Barbara. Oh, God, the top. I like that, yeah. Oh, thank you so much. Any other questions? Please don't be shy. I'm just loving the way we are all contributing. And yes, thank you, blessing.
I hear, I'm not really sure how true there's like a misconception among the youth that breast implants actually stop you from developing breast cancer. I don't know how true that is, but it's on the internet, so I'm just wondering.
Okay. Thanks for that. Yeah, Barbara.
To the best of my knowledge, there's no scientific evidence of that. If anything, breast implants can actually be a risk factor for breast cancer. And the reason is, when the implant comes in, it covers the normal cells. And for instance, Laura, please come on. So let's say I'm breast tissue, and Laura is implant, and she stands in front of me in the breast. And so, like I showed you about doing the breast examination, an implant is actually like silicone. It's already smooth. And they feel for this smooth surface. What do they think? It's normal.
Yeah.
Whereas they cannot feel the abnormal tissue behind. I've had people, when they come in, they say, oh, can you examine my breast, doctor? I'm not too sure. And when I feel it's silicone there, I cannot feel the tissue underneath. I cannot tell them. In that case, we have to refer them to the breast clinic, because you cannot. So if anything, it puts that individual at risk of cancer, because you cannot feel the normal tissue. So yeah, there's no positive in it, apart from the fact that they can break. They can. I have felt it. I have referred people with broken implants. Unfortunately, breast consultants can be a bit funny. If it's broken, they will say, go back to who did it. 9 out of 10 times it was done privately, and now they've come on the NHS to try and, so there's a lot of, so I am yet to see the positive. We do it, unfortunately, what is done privately is different from what is done following a mastectomy. That's a completely different thing. You know, for cosmetic reason, the implant is, it's different, and then and as my organ on the top mentioned, there are surveillance. So when someone has had breast cancer and they've had a mastectomy and something else is that they are under surveillance and that is being monitored. Whereas someone who has an implant, who's monitoring that? Who can see the breast tissue? So yeah, it's got its own risk. Thank you.
Thanks for that. Yeah. Yeah.
Identify what's wrong early enough, and by the time something becomes obvious, it's probably too late, and you've probably developed a spread to other organs. So having an implant is a risk in itself.
All right, thank you for that. Yeah, I'm just glad we mentioned that, because these are some of the myths that we're talking about in our community. That young people say, "Oh, go and have a breast implant. You're not going to have cancer." So I'm glad we mentioned it today, because we won't actually any mates, anything that people say, oh, if you have this, if it's good to say it in group meetings like this, so that people can know, and then they can take it on and pass it on to friends, families, and all of that. Amazing. Thank you. Any more questions or contributions? Go on, Chidi.
I don't know if I should say this is a question or a contribution, but it's my own issue, In my groin area, for the past 2 years, I've been noticing a lump, and I visited my GP, and they took me for a scan and all that, and they came back and said it's cancer-free. Why I'm talking about this is because of what Dr. Barbara said, that when there is any abnormality in any region, it can lead to cancer. So in my case, where the GP has said it's cancer-free, and I still feel there's an abnormality, what do you think about it? Do you think that can also lead to cancer, or I should just believe what the GP has told me? Thank you.
Without trying to go obviously into your personal history, there are reasons why we can have lumps. They are, in our body, we've got over 200 things called lymph nodes, which are glands in our body that respond to infection. If you have young children, you probably will notice the one around the neck. When they get tonsillitis, cold, they swell up and they go down. Those are glands. It's one of the things that I can suspect will be in the groin of an individual. Don't forget, not every lump is cancer. So what I suspect your GP was telling you is that lump is not cancer. It's very different from saying, so in the groin area, especially if we walk about barefooted, or if you've had a cut, or if you've had a leg infection, the lymph node, because like I said, they're all over our body, they respond to infection, they're very good. In fact, if they don't respond to infection, we worry, because that means that person's immunity is low. So your lymph node will swell up in response to an infection. They may not always go down, which is fine, but what we need to do is to check that these are normal lymph nodes, which will be seen on an ultrasound scan, and we say it's not cancer, it's a lymph node that has swollen, and it's fine. In fact, we do that most this week alone. I've had some children that had nodes that were swollen and weren't going down. We scanned them, and I was now telling their parents, these are normal glands. There's nothing to worry about. They may never go down. In fact, if one of my daughters had come in, I would have shown you hers, because she still has some swollen from tonsillitis. So that's different. Sometimes we may have a hernia, which is a push of some internal organs coming out, forming lumps on our side. Again, that's not cancer. That's a lump, just not in the right place. So when we say cancer, we are talking about cells that are behaving abnormally. A lymph node being swollen is a normal response to immunity, which is normal, which is fine. We expect your body to do that. That's different from a cell behaving abnormally, communicating to the adjacent cells, and they all begin to behave abnormally. That's very different. So there can be lumps and swellings, which mean, in fact, even in the breast tissue, there's something called fibroadenoma. There are some women with breast lumps. They are not cancer, but they are lumps. They are tissues of the breast that have swollen and are just there. They are fine, nothing to worry about. Again, we say keep checking that they don't change. The moment they change, come and see us. In different parts of the body, even in the womb, when I was talking about cancer of the womb that can form there, there's fibroids. So sometimes fibroid, again, is swelling of the womb. That's another swelling, but it's not cancer. The cells in the fibroids are still normal. So in the same way, the cells in the lymph node that are swollen are still normal. Fibroadenoma, they are still normal. These are all normal structures. So you could have swellings that are not cancer, but are there. So that's a slight difference. Okay.
Thank you.
So fibroids, all the cells there are normal. Can a normal cell become an abnormal cell? We've already discussed. It is possible. It is rare that fibroids on its own will just become cancer, but we know that cells, any cell in the body, can begin to behave abnormally. So it's not impossible. But normally, it's just like we have more people without cancer than people with cancer. In the same way, you have more normal fibroids than swellings in the womb that can progress. When I was talking about the breast, saying the fibroadenoma, and I said, if the swelling changes, come back, there are people who've had breast swellings that were normal, and all of a sudden an abnormal one just appeared, But the most important thing is we continue to look at ourselves to know what is normal. And the moment something that doesn't add up appear, we look out for it.
Thank you. One more.
Thank you once again. I think the last two questions are very similar. And I agree with everything Barbara's just said. But I just want to reiterate the point she's made. The fact that you've got a swelling on your body does not necessarily mean it's cancerous. But how do you know? Get it checked. And once you're informed it's not cancer, it's something benign, you still need to keep an eye on it, because every potential lump in the body could transform to become cancerous. So a swelling anywhere in the body that has been investigated and been said to be normal doesn't mean you should forget about it. Keep an eye on it. Fibroid, keep an eye on it. And once you notice anything, even if you're not sure, go get it looked at. You never can tell. Thank you.
Thank you. Thank you very much. Yeah, sorry about that. Okay. Thank you for all your questions and contributions. Any last one, final one? Before we because Barbara has another event she's speaking at, so we're going to let her go in a minute. Any more quick questions, last minute questions? No, are we all happy? Any questions for Dr. Tola as well? Any more? Regarding the male cancers or the general one he spoke about, lung, bowel, prostate? No? Okay. Amazing. Thank you so much, Dr. Barbara and Dr. Tola. We're going to keep you for a bit. For a bit, please, because I'm going to bring up to the stage, pretend stage, someone with lived experience of cancer. Beautiful woman I've known for so many years. She'll be sharing her story and then telling us what she looked out for and how her treatment. So that we don't think cancer is a death sentence. Cancer is just like how you have diabetes or how you get high blood pressure. That's how cancer should be, because we want to try and prevent or stop this fear of the C word. No, it is cancer, and it is not a death sentence. If it's caught early, trust me, you can go back to your job. So I know somebody that actually had a baby after breast cancer treatment. So life goes on, but it has to be caught early. So I'll bring to the stage Pamela, but let's say thank you to Barbara first of all. And thank you so much. One second. Okay, yes, please, let's do a photo, yes. Bye-bye. Let's bring it back again. We haven't done it yet. Oh. Thank you. Thank you very much. I'm just trying to. 1 second. As my caterer, no, she just caterer not good bring food though. I wanted to give you and I'll bring home for you. I'll bring your jollof rice. I have special jollof rice. Let me just call her quickly. I need to know where she is. All right, Dr. Nessie, thank you so much. Okay, yeah, yeah. Okay. Yeah, we're on here. No, we're over here on this side. Please, where are you? Come here. Come to Anna. We're gonna bring the food lunch. I'll speak to her. She's lost. Please. Can you imagine?
Where exactly are you now?
Okay, go on in. Yeah.
Come here. Oh, thank you. You smack me?
Okay, yeah, thank you very much once again. So, the caterer is just trying to bring our lunch because that's also very important. Our lunch is for this meeting is really important. She's lost, so I have to just give her a quick call. Okay, so I'm going to bring Pamela to the stage to share her story, and then we can all have so it's going to be like a chat. Feel free to ask questions, after when she shares her personal experience, ask questions. And so if there's anything that is bothering you, if you know a family that's going through cancer right now, this is like a platform for us now to have a chat about it. I'm thinking we should maybe face them if you don't mind. Yeah, so we're going to just sit and then, so that we can. So Pamela. Yes, come please, yes. Round of applause to welcome her. So I'm just going to put our seats to face the people here, so. No problem at all. Yeah. Thank you. If we move a bit closer so that it's not. Yes. Okay. So you have your microphone, yeah? I'll give you this one for later, yeah. Okay.
Good afternoon, everybody. Can you hear me? Yes. So my name is Pamela. In 2017, I got diagnosed.
It's on, yeah.
I got diagnosed with stage 4 non-Hodgkin's lymphoma, which is, if you remember, the other doctor was talking about lymph nodes. It was cancer of the lymph nodes, and it was stage 4 because it wasn't caught early enough. So basically, what happened was I had my son January 2016. And when I had my son, I remember the consultant said to me, I think you should get yourself checked. There's something going on. Just go talk to your GP. But at that period in time, other things were going on in my life. So I just forgot. I didn't think much about it. And I became a single mom, and it was just survival mode. So the last thing I thought about was going to the GP. So come December 2016, I started feeling funny. I started having night sweats, constantly having night sweats. And I started having this pain on the top right there, at the top upper part of my abdomen. Of my, right below my diaphragm. It was quite painful. When I lie down, it would hurt. And I was thinking, what's going on? So I went to the GP, and it took 7 months up until July 2017. Up until June 2017 for the diagnosis to be made, because there were no physical symptoms. But because I was seeing the same oncologist, and he was just come for blood tests. Every 2 weeks I would go for blood tests, and I thank God I like needles, because if not, it would have been another nightmare. But literally every 2 weeks, go for blood tests, and they're like, Pamela, we can't see anything. But they knew something was wrong, but they just couldn't see anything. And I went for the mammogram. I went for all sorts of tests and screening. But the point where I remember Dr. Roland was like, Pamela, you're losing weight. You're getting tired, extremely tired, and you're losing weight too fast. What is going on? That I think I know what it is now. And at that point, did another test, and when I went back, I won't forget, not Manchester Hospital then, he said to me, well, we're sorry, it is stage 4 cancer, and they showed me the scan where it was red hot, like literally everywhere, it gone everywhere, excluding the brain, thank God. Because they said at that point it could have been in the spinal cord, because they found traces in the spinal cord, and if there were more traces and had gone to the brain, it would have been serious, like at that point it would have been really, really serious. But then they said, the doctor said, I remember him saying, we need to get you treated ASAP. Like, you need to come back in. We need to do, how quickly can you come in? And, oh, yes, it's a very, very painful thing to hear. I would not lie to you guys. Because I remember I was sitting there acting brave. I was like, okay, it's cancer. Oh, it's stage 4. That's fine. It's okay. And I took the letters they gave me, went out of the office. And the first person I called was a very good elderly friend, a mentor of mine, Dr. Samuel. And I said, Doc, this is what they're telling me. He said, oh, Pamela, but I know you're a woman of faith. You don't worry. But, oh, Pamela. And when he said that, I broke down crying. Like, I just cried. Every cry you can think of. Cries I probably haven't cried since I was born. I cried it that day because I'm thinking, are you joking? How did this happen? And I remember sitting in the car park because I had to go pick up my son. I couldn't go drive. And I just sat there again, and I cried, and I cried, and I cried. And then I went, picked up my son, went home. I didn't want to tell my mom, because I was like, she's elderly. This woman is probably going to go crazy in Nigeria, thinking, what's this girl going through? Because obviously, when at that time, again, not me knowing much about it, what you hear is anyone that has cancer dies. So I'm thinking, am I going to tell my mom this, or what's going to happen? So I kept it for like 2 weeks, and I was talking to another mentor of mine who's late now, where she was like, we're praying, like, look, Pamela, what are you going to do? So I said to the doctor, I remember saying to the doctor, oh, I'm going to do the treatment. The doctor was like, yes, you have to do it. Go ahead. But when I called my mom, African mother, she said, don't do the treatment. The treatment will kill. I'm like, are you joking? Like, I'm like, are you for real? Like, if I have a headache, I take paracetamol. So why are you not telling me not to do this treatment? It's like, no. They said if you do the treatment. I said, who are the day? Let me know. And this was literally, like, don't take the chemo. If you take the chemo, it will kill. I'm like, oh, what are you on about? That look, I have to try something. I can't just keep quiet and not do anything. That not doing anything is even worse. And eventually it took like Dr. Samuel and some other person calling her and saying, look, she has to take it. I'm like, I don't even care. I have to take it. You like it or not, you pray for me, I'll be fine. And she then agreed. She's like, okay, go take it. I'll be praying for you. I'll be supporting you. I'm like, that's fine. Chemo was hard, I'll be honest, because it was one of those ones where I think it was every 3 weeks. I remember that's how Almost and I got closer, because you just feel weak. You can't do much. And then an 18-month-old son, everyone was taking care of him. Half of the time I wouldn't see him. And it began to affect him as well, because by this time he was getting to 2 years old. He never sees his mom. Mom is in hospital today. Tomorrow she's looking bloated. The next minute I had to cut my hair off. And everyone was like, was this a midlife crisis for Pamela? Not knowing what I was going through. So chemo was tough in the sense that if the first thing I would say to people when I meet people that come to talk to me, I say, never give up. Because it gets to a point you feel like giving up. Don't give up. I'm a firm believer that if you're resolute enough and you don't give up, come what may, you'll get the best out of it. I am a firm believer of that. Never give up. Because there are times in hospitals that you're thinking, God, I'm tired. I can't do this again because of the pain, the aches, and the stuff. And there are times where the nurses will forget to give me the anti-sick pill, and I'm constantly throwing off. And by this time, I brought my mom over from Nigeria because I needed help. I needed someone to be there with me, and I brought her over, and my mom would be cleaning my vomit on the floor because I couldn't, everything was just, coming out. And I remember doing the first 9 chemotherapy sessions, and Dr. Roland again would say, Pamela, it's not getting better. I'm like, okay, what do we do? He goes, well, I think we moved from R-CHOP to DAP. So he said he was going to move me to this higher dose chemo that he thinks this is going to blast it off, da-da-da-da-da. I'm like, okay, we'll do it again. Then, and believe it or not, during this period, so the way chemo works is you go chemo 1 week, then you have a 2-week break. So you do a blood test again before the next chemo. And I think if anybody here knew me, you wouldn't have known what I was going through, because if you call me for a party, I will go. If you say, Pamela, let's go to the cinema, I will go. If I feel tired, I'll probably say to you, oh, look, I feel tired. I don't feel like coming out today. But the moment I have that 1 week where I've got the energy, I kept up with life. That I kept up doing everything I could do. I would not, I mean, a lot of people will found out, so I run a business. A lot of people will found out what I was going through, were shocked that we're still running the business and I was still living life and just managing myself. Because at the end of the day, it wasn't a death sentence. Every moment I woke up, I am alive, I was alive, and I am still alive, and that for me was key. But then when the second higher dose of chemo started, it was, I remember it was January 2018. It was really tough because I was just really draining. And after 3 sessions thereabout, Dr. Roland said again, Pam, it's not getting better. And at this point I wasn't worried. At this point, I was just like, you know what, I'm going to go out with a blast. Whatever happens, that I'm just not going to let anything dampen my spirit. But I thank God for brothers and sisters in church that were praying for me, because, again, I'm a woman of faith, so forgive me. I don't mean to offend anybody, but I cannot say my story without referring to my faith. After all the treatments and everything, miraculously went for the tests, and it was all gone. Like, not one trace was left. And I'm thinking, I'm like, but it doesn't disappear like that. It should be gradual. And they literally did a scan, and it's like, look, Pamela, nothing, not even like, oh, residue is going to go, nothing. I'm like, just like that. And I remember the doctor saying to me, and I looked at him, I was like, you've got to be joking. Like, all of this for to just go like that. And he was like, look, Pam, last 2 weeks, it was still full-blown. We're having meetings to see what we're going to do. But this time around, it's all gone. I'm like, just all gone. And again, this is where my faith comes in, because it has to be something supernatural that happened. But then after this now, so because of the kind of cancer it was, and that was why I asked the question earlier about how long before the cancer can come back. Because there was lymph nodes, I was then recommended to do a stem cell transplant. And I thought I'd done it all with cancer, with chemo, not knowing the stem cell transplant was another journey of its own. And the advice was from a consultant that with lymph nodes, non-Hodgkin's, stem cell will help prevent it from coming back. So basically what they do is they kill off they take out the good cells, multiply it in the lab, kill off all the dead cells in the body, like with the highest form of chemotherapy, whatever, and then reintroduce the healthy cells into the body. And all things being equal, the body should accept it, not reject it, and everything should go fine. In my case, I now developed an infection that put me in coma. I lost my memory. This was all in 2018. And I came out, when I came up, everybody was like, she's back again. I'm like, I'm not going anywhere. You people don't get it. You guys don't get it. I still have a long time to go. And I'm laughing now, but that's the truth. I remember then, I was like, you guys are joking. I ain't going nowhere. Long story short, I'm still here. My son is still with me. My mom now lives with me. She's permanently residing with us in the UK. And I'm always happy to get the opportunity to talk about this to people, because I laugh about it now and I joke about it now. But there are times when at that time, it makes you appreciate life, your body, rest, laughing, because laughing does wonders to the body, being positive, and just that relationship with your GP, with yourself, with the information you get, and just hope in everything. I don't take it for granted in any way whatsoever. I got I had the all clear in 2018. I had a stem cell transplant in 2018. The doctors were like, oh, Pamela, it may be difficult for you to walk and drive because of coma, because of this. By December, I was up and driving, within reason, because I would drive a little. I remember when I came out of hospital, finally, it would take me 1 hour to walk from there to there. Because I was that weak, my bones, I had to do physio and all of them. But today I'm driving up and down again. I'm doing things. I mean, COVID happened. I did not get COVID. I mean, I was the first person that got the letter to say, what's it called? What's that word?
Self-isolation.
Self-isolation. But then with self-isolation and everything, I think my mom had COVID. The carer that was coming to our house for my mom had COVID, but I did not get it. And you're thinking, this is me that should be the first one that everybody's panicking about and everything. And I think at some point in time, I even braved it with you and said, you know what?
Volunteer work.
I'll do some volunteer work. There's nothing is holding me down. But again, don't mind me. I make it light now because it's happened. But it's been since 2018. I think this is the 6th year, counting by the grace of God. Wow. And I think it was in June, I went to the doctor and they're like, oh, Pamela, you don't need to come up for follow-up again. So the gentleman that was talking about the follow-up care is very correct. I was told I don't need to come for follow-ups again, that look, everything is, the blood test, everything is looking fine. You don't need to come back again. But one of the things Mission I do now is with likes of Laura and anybody who calls, I come to talk about it, to say, within our community, if I'd listened to my mom and not done the treatment, I don't know what would have happened. I don't know. I'll be honest. I have a friend who is going through a similar case, and she said she's not taking the treatment. She's not taking it, and she's getting worse. But we're praying to God. Well, who knows? Maybe that's God, how God wants to help her. It is very important to listen to the doctors, to follow the instructions that they gave, the advice they gave. Of course, get second opinion wherever possible if you're not sure. Very important to do the little things they say. I mean, the one when every time everybody's talking about cancer, they say obesity. I'm like, hi, I've been suffering to lose weight. I don't know what to do to lose weight, but that's the one thing I hope that God will help me. Because if they say obesity, my BMI is way off the roof, off the charts. But I'm praying that at least the little ones I can do, like my walk, I do my walk, normal walk a day. I drink my water, my fiber. I have come to appreciate the rest because I've come to realize that run all you can, do everything you can. At the end of the day, if you don't have the health to enjoy it, what's the word? So I sleep, I rest, I take my time, I apologize where I need to, and I'm happy. And I come out to encourage people and say, look, it's not a death sentence. I am standing and I'm still going to be here for a while. So that is my story. Thank you.
Wow. That is explosive. And anytime I hear Pamela's story, even if I hear it like over and over again, there's always something new. Like, you know, her faith, she's not going anywhere. And then, like you said, if she had listened to her mom's fear, her mom had all the good intentions. Because, like, from what people say, is it myths and beliefs, cultural beliefs, chemo kills. But okay, why don't you just try it? People have done chemo. Look at Pamela, she's here today after 6 years, cancer-free, because she went for the treatment. But people say, oh, don't take chemo, but then they end up dying. You know, there's cases of people, they don't want to take it, and then at the end of the day, we lose them. It's sad, and so it's a powerful story, and just show us that people come through, they come through at the other side of cancer. Cancer is not a death sentence, If it happens, it happens. Just brave it and do what you have to do, and then do all the follow-up tests and all. Dr. Tola, any input? Just let's have your
Yes, that was quite encouraging, and indeed you're a brave lady. And yes, I think quite a number of lessons has been picked, like Laura said. Yes, demystifying it, and avoiding, or as much as possible, fighting through the myth about cancer. Of course, yeah, at the extreme of the spectrum, that's the thing that people fear most. When you're talking about anything, you think about more of cancer. Now, do we know there are many other things that can actually kill people, apart from cancer on its own? Okay, different other things that put people at a higher risk. If there were anything to be arranged in order of risk factors for death on its own, cancer probably wouldn't be on the top of the list. So if we're able to actually demystify it and approach it with the braver as you approach a chest infection, diabetes, stroke, or things like that. If it happens, yes, it does happen, but main thing is never to give up. Okay, being brave and going with whatever is available in terms of the treatment does help. 20, 40, 50 years ago, when we're talking about HIV or AIDS, many people would have died from maybe either the depression or other things, which they could have lived through. Up to now, many people are living with HIV and they're not effective because they're going on with the medications. As the same fear that AIDS brought into the lives of many people then, that, it's like a death sentence. Similar thing, cancer has always been. It's most likely will continue to be.
So, and we have to, approach it and be who we are also. Okay, so yes, I think going through that, it would have been quite challenging. I can imagine many ideas come in, and people that have your best interest at heart, they have the best, but what they give also might not always be the right or the best approach. And like Laura said, with good intention, yeah, and if, like the medical treatment, everything has its own potential side effects or complication, but it's not everyone that experiences that complication. And if you have just two options of either living with it and declining or deteriorating, and there's a sort of a wild card to say, okay, this is a way out, think you lose nothing by actually going for that wild card. Okay, who knows? That might be, and who knows? It could be the next Pamela. That's it.
Yeah.
Well done, Pamela.
Oh, thank you. Thank you for that, Godzilla. Yeah, amazing. So I'm going to leave the floor open for another 5-10 minutes. Bring your questions. We've got Pamela here to, if you have any relative going through cancer right now, yourself, if you've had in the past and anything, let's like the chit chat now. So let's do another 5-10 minutes of that chit chat. So floor open. I'm going to borrow. Okay, let's borrow Dr. back here. Yeah. So any questions? Yes, Auntie Kate.
Sorry, thank you. Mine is not a question. It's just to add with what Pamela said and what the doctor said. You see, we bring faith. Yes, we have our God. We have some Muslims say they have their Allah. We worship, but at the same time, when we have sickness like cancer or any other sickness, we know that God will help us. At the same time, we should not refuse treatment. We should have both of them, and the Lord will guide us through. That's my own advice.
I'm here. Ask my questions. Don't mind me. Laura is not here, so.
I can just speak on that. Thank you very much. Indeed, you're right. Because our complete being, it has to do with something we can't explain. Then we talk about our body. At least for us to know that we're complete, we can only move our body because there's something in us. And that, I believe, has to do with the spirit. So if we don't have that thing in us as a spirit or as a breath, then we're not moving the body. So, the place of faith comes there also, I agree. And it's something that we do encourage also, that, yes, apart from maybe part of the lifestyle measure, apart from, avoiding dangerous things, sleep, good diet, lifestyle exercises, that does come into play also. Positive thinking, being hopeful, thinking more of, the outcome as being positive. It's something that could be encouraging and could actually have an impact on individuals' physical health. Little wonder why we have things like cognitive behavioral therapy, which cuts across everywhere, including, approach to cancer treatment also. Cognitive behavioral therapy just help people to fight through and overcome cancer also. Thank you very much, ma'am.
Thank you. Any more questions or contributions? Anybody? Feel free. Any stories you want to share? One quick last word.
Oh, by the way, I forgot to mention. Okay. So my dad died of cancer, just so you have an idea that it runs in the family. And if anyone was at a high risk, definitely I was, but I didn't think much of it until everything happened. So the reason why I'm mentioning that is because if Dad died of it, did not mean I should die of it. So just because someone in the family is gone with it does not mean anyone that has it should follow through. No, it doesn't follow. It's just unfortunate, but yes, we can pull through.
Thanks for that addition, Pamela. Yes, because from what you said, family history, from what the doctor said earlier, is also, family history. So if a parent had cancer in the past, if we're a grandparent, then you should look out for, really, breast cancer is hereditary. It's very, my dad also passed from cancer. That's why I started the charity after my dad's passing, the pain and everything. I said, I'll just channel my energy into, community awareness. So after my dad passed, I had should I say a lump? Or no, when the barber is saying you have to check yourself, I'm not going to say I check it every month, but from now I'm going to actually promise myself I'll be checking it every month. To be fair, we do the preaching, but do we really do what we preach? Yeah, so I'm going to take it upon myself today. Every month after my period, I'm going to make sure I check my breast. So, you know, after my dad passed, I was like, oh, okay, I've read now that it could be hereditary. But then there's this lump it's a hard, like a tissue in one of my breasts. And I went to my doctor, I said, doctor, please, check it. He said, they think it might just be it's a gland. It might just be. I said, I don't care, just send me. In fact, you know what I said? Send me for a mammogram. Because my dad died a year ago, and I'll be having, like, you know, like when you have dreams and things. Could it be cancer? So, and they were like, I was like in my 30s, and then they said, okay, no problem. They sent me for a mammogram. So I went for it, and they said, okay, no, it's just the glands that got that and everything. So yes, at least that peace of mind came as well. Yeah. So it could be anything that's bothering you. Just make sure you have it checked. You can never be wrong in checking. You can never go wrong with that. Yeah.
Yeah, and it's true what you said, Laura, because remember when I said it took 7 months for them to diagnose. At some point in time, I almost gave up in going to the hospital. I'm like, why are you guys just taking my blood? It got to a point my mom was like, pray on the blood before they take it. Because they're just every minute, blood. But every 2 weeks, blood. But yet nothing was coming up. They weren't seeing anything. How do you keep going to the hospital for 7 months, constantly every 2 weeks, doing blood tests with no results? It gets to a point you're thinking, this is a waste of my time. But the good thing about the system where we are, the country where we are in, is because I told my employers then, I said, look, the doctors want me in 2 weeks. On a Thursday, I will not forget. My employers made sure that Thursday afternoons, I was free to go get the blood test so that and I worked up the hours later. And the system will support that. But if I had given up, at some point, because imagine every 2 weeks, I know North Manchester car park so well now. I know where to go and park. I know how many minutes it's going to take me to get there. And even when I got there, I'll see the phlebotomist. And they're like, oh, Pamela, hi. I'm like, oh, hi.
Family.
Family. Because every 2 weeks they saw me. But imagine if I had given up and just said, I'm tired of this thing. I think I missed it once. And Dr. Samuel again would say to me, Pam, you need to go. You need to go. Don't miss it. It was Dr. Saman. There's another gentleman, another doctor, Dr. Akin. Those two I used to call. And they're like, no, Pamela, you have to go. You cannot miss it. Just keep going. They'll figure it out. But that person, that not giving up again, because sometimes it's tiring. 7 months of going to the hospital every 2 weeks.
Wow.
It's not nice. But yeah, so it's, again, not giving up on your GPs if they're asking you to come in, or you think, oh gosh, it's every time coming in. At the last time, they now saw what they needed to see.
Amazing. Yeah. Any last word?
I think Pamela said it all.
Honestly, it's been an amazing afternoon. Any last word from our lovely participants? Have you all enjoyed yourselves? Have you? Yeah. It's honestly, even me, I've enjoyed. Oh yeah, we have to do this over. I wish we could do it like every month. Just come together. I'll get jollof rice ready. Trust me. I'll make sure there is jollof rice, and we have to make sure Dr. Tola is available. Dr. Bun jollof rice. Yeah. No, now we are free to eat bun. We are free now to eat bun jollof rice. So yeah. So honestly, if we had the opportunity, I would do this every month. But we meet here every week for like everybody that is here today. If you've not been coming to our sessions, we have like a small group meeting just next door, opposite here, every Friday. So we're here Friday between 10:30 to 12:30 in the afternoon. So we have that chat. I know it's a smaller group, but if you're free, if you're not busy, you can come. You never know. It could just be a chat that day that would click and say, okay, let me go for this check or let me go for this test. And then we also meet in Longside on Tuesdays. So we have 2 meetings every week. So and for the past 5-8 years we started now, say after the pandemic, and then 5 years fully, we haven't closed our doors. Tuesday and Friday were at the community centers, Longside on Tuesdays and Fridays here, and then we do our meetings, and then bonus.
Longside.
Yeah.
We also run a session in Longside in Urdu, Punjabi,
okay.
English.
All right.
Somebody,
yeah.
can't speak English.
Okay. Yeah, all right.
Every Monday until 2 we are there.
Okay, we'll connect it to you. Let me give the microphone to somebody at the back here. Thank you.
Good afternoon, everyone. Good afternoon, doctors and the panel. I so much thank God for the awareness of cancer that is going on. I think it's throughout the world now that is going on, and I really much thank God for what they are doing, even in UK at the present moment. It really helps everyone that sometimes that might have died, but God really helped the doctors and all other panels to save their life. We thank God for that. But one thing I want to ask is that with the long stay, awaiting appointments in the hospital and even in the GP practice now, what are we going to do with that for those that are supposed to get appointments sooner or later, so that something that will be done quickly can be done to them before it goes to the last stage of cancer treatment. So what are we going to do to that, please?
Thank you. So, yeah.
Oh, thank you very much, ma. There are some, some measures in place. Unfortunately, it might not be as efficient or as effective to meet our needs or expectations, but to a good extent, some systems have been put in place. Things like maybe the different screenings that people have, because right from childhood, when we're born in the hospital, there is a screening done within 72 hours, and that's because there's a cancer that could occur in that of the eye in a baby. So things as early as that can be picked up. So regular screening, so that's a 3-day screening within 72 hours. That's a 6 to 8 week screening. And as we're maturing, screening measures are being put in place for the age. Now, it doesn't mean that we need to wait for those to check maybe, oh, there's a risk of cancer or not. And that's where the things about, if you notice anything not right, always check. Now, I appreciate that the system might not be as efficient to accommodate everyone, and that's where the persistence comes in. If you notice anything not right, contact your GP to get an appointment. It might not work the first or second time. If it's getting persistently deferred, then there's a chance of just walking in. I know most appointments are often by phone or online, but as long as you give the details in the place, the GP will always use their skills to know maybe, oh, this is significant. That's what we call red flag. So when someone comes and just says, having a symptom, we explore, and even some systems are in place also, like AI, to check, to be sure there isn't what we call the red flag in the individual. If there is that red flag, that puts that person higher on the list. They prioritize the person, and the person will be seen much more earlier. So that's often, restricted to the individual GP surgeries. But our own measure is to, or let me say, our own responsibility is to respond to any screening, call for medical attention when it's needed, especially when we don't know what's going on, and be persistent with it. And at your GP surgeries, if you're still feeling worried, you call, because I know most places they'll say call from 8 o'clock, and by around 10 minutes past 8, all appointments are gone and things like that. You can actually walk in. If you're still meeting roadblocks, request to speak with either the GP principal or the practice manager. The practice manager will always sort you. They will know how to, go about things and ensure that you're sane. Because there might be challenges about you waking up between 8 and 8:10 to call, and every appointment is all gone. In such a case, go ahead and speak with the practice manager. Okay, and things can be put in place. The delay is not something we want. We want things to be sorted as soon as possible. Unfortunately, the system might not be able to accommodate everything, but that's not your individual fault. So the mandate is always call for medical attention, and you can actually walk in to ask or request to speak with the practice manager.
Can I? Yeah. I was going to say something. You're very right, sir. So, my mom now stays with me, right? She's elderly, and unfortunately, she's now blind, so I have to take care of her, and she lives with me. And my mother, I hope this helps you much, just to give you, it's not cancer related, but it's something to do with GPs. So she said to me, she said, Pam, I'm feeling this pain on my back. I'm thinking, what kind of pain are you feeling? Because, you know, elderly mothers, with all due respect now, they can sometimes be, I have a pain, I have a pain, I have a pain. And you just get tired of all these pains that leading to nothing. So this particular day, I just said, okay, you know what, just let me look at it. And now again, I think one of the doctors mentioned, was it you said, that mentioned our high pain threshold.
Yeah.
She had a sore she did not tell me about. And this sore, for some reason, she used the African way of scraping it and cleaning it, and it was getting bigger. And it had become a bed sore that I wasn't aware of. So when I looked at it, I screamed. I was like, what? I had to call off, like, going anywhere that day. And I literally started crying. I was like, how could this happen under my watch? I called the GP, and the GP said, oh, well, we're fully booked now. You'd have to, this was, so I saw it at about 6 a.m. By 8 a.m., I was already calling. The GP said, well, there's nothing we can do. There's no appointment. Call 111. I'm like, call 111. So I called 111. And 111 is like, well, you can go to the nearest A&E, I think it was, walk-in session. Yeah. But I'm thinking, walk-in session, how can I even carry? I'm even afraid that I didn't know what to do. So I called a friend of mine who was a nurse, and she said, Pam, call back your GP and say to your GP, you're afraid that this is so bad, it may be sepsis. That if they don't know, they would understand. When I called the GP, and that was when I realized that you can actually take pictures and send to the GP. Yeah. I did not even know that. So when I called back the GP now said, the person who now picked up the call said, can you take pictures and send to us? This is me still thinking that they'll probably come back and say, it's not that important. So when I took the pictures and sent the pictures, within 5 minutes, no, for about 4 minutes, first person called me to say, someone is calling you now. Within 6 minutes, another doctor had called me. Within 8 minutes, somebody else had called me. The pharmacy had called me. It was only then I realized it was a grade 4 bed sore. And that is dangerous from what they said, because that could have led to sepsis of some sort that I had never seen before. But again, because I just kept, because Mom asked the question, because I kept on checking and checking, what can I do, what can I do, what can I do? And eventually I figured out, rather than making it seem quiet and say it's just a little sore, make them realize that you may not see this, but I see this. And from speaking to a few people, I know this is serious. Within, 1-2 hours, antibiotics, everything got delivered to the doorstep. I'm like, oh, wow, I did not know, our NHS service was that good, because I'd never experienced that before. So again, I realized with the system, it is persistence. Because I would say to myself, they're humans as well. They speak to 20, 30 people in an hour. They probably would never, ever understand how important or how bad what you're feeling is if you don't explain properly. So if we as black BAME women, actually, we think the threshold is 2, in reality maybe 4. So maybe you want to start going and thinking it is actually a 4, not a 2. So when I'm saying it, I say it as a 4, not as a 2. And if truly it is a 4, then it might be even more than that. And so you can imagine my mom having to go through all that pain, not saying anything. Again, black woman, I can do everything. I don't want to disturb my daughter. But within 3-4 days, she felt better. Because again, we persisted, we called on the right people, 111, everything. And it was now on record to the point where I've never seen, sir, with all due respect to doctors, I had never seen that kind of speedy answer the moment they saw the pictures. Within 2 hours, the medication was there. Everything was there. Bang, bang, bang. But then if I keep remembering what people say, oh, there's a long queue, I've been discouraged. So again, we have to just be persistent. Like, take pictures. Call 111. Let it be on record that, look, you're trying, and not just, and within 3 days, this woman was fine. She was feeling a lot better. And even she herself admitted, she was like, oh, I'm sorry. I am so sorry. I did not realize this happened. So yes, I'll just say, please just be persistent. I can never stop saying that. Just be persistent and let them know. Take pictures, keep records. So when you're talking, there's something to show them as well. So they know that you know what you're talking about. Oh, and that's another thing I've learned to start doing. When there's a pain or anything, I keep records. 6 a.m. filling this, 7 a.m. filling this, oh, 9 p.m. it's gone.
Yeah.
Oh, 1 a.m. filling this, 2 a.m. filling this, 3 p.m. filling this. Oh, day 1, day 2, day 4, it's gone. Okay, I'm okay. But there's that record. Because the more records we keep, when we're talking, sometimes we forget that, oh, it happened 1 a.m., it happened 3 p.m. We only remember the most recent one. Whereas if you have that record there, when you're telling them, you're like, look, at 1 a.m. this happened, at 3 a.m. this happened, at 6 a.m. this happened. Immediately they're thinking, okay, this person knows, this person is not making this up. There's something to show. And it also helps them to quickly react. I am not a doctor, but I've just been through the system so long, so forgive me. Forgive me.
Thanks for that, Pamela. Yeah, that's amazing. Yeah, so honestly, you know, that word persistence is really important. If you go to your GP and they say no appointment, tell them, I suspect it's cancer. Like, you know how you said it might be sepsis. So things like that. I know you can actually say. So when you tell GP, I suspect it's cancer, they would call you in. Whether there's 20 appointments, they will call you in before, because once it is suspected to be cancer, there's a very quick, fast turnaround time for that. So yeah, I think if you want to quickly say something about that as well. Yeah.
Yes, and once the person is or the individual is seen by the GP, that's a let me stand up for a moment.
Okay.
Yeah, that's a pathway that we call 2-week wait. So it doesn't stay at the GP. The ball doesn't stop there, because we're limited in the investigations and everything we can do. But the hospital investigation does give us more specific conclusion. So that's what we call 2-week wait. And specific instruction is given when a referral is being made to say, this is a 2-week wait. And the reason why this is being done is we're suspecting cancer. We're not saying it is, but we're suspecting it. And the hospital has a system in place to attend to such. So the system is, you should be contacted very soon. So it's not like a 6-month or 1 year wait. So usually people are contacted within a week by telephone or something to let you know that, oh, your doctor has made a referral because they are worried about cancer. Are you aware of this? And yes, once you consent that, yes, I do know. The reason why it's called 2 weeks is you should be seen within 2 weeks. So not beyond 2 weeks. If the appointment is going beyond 2 weeks, you should let your GP know, just to give room for any system error, that maybe there was a system error in the communication between the primary care that's in the community and the hospital. But ideally, you should be contacted within a week. Some places say within 3 days. You should be contacted and you should be seen. You should get an appointment within 2 weeks. And that's why it's called 2-week wait. They call it fast track also. So especially when that trigger is said that suspicious of cancer. So some measures are in place to accommodate that.
Thank you. Thank you very much. Wow, that's been an amazing session. So, in fact, we actually made it. Look at the time. It's a few minutes to 3. So, yeah, even with this slight delay with technology, it wasn't our fault. We were going to start early. A lot of you came early as well. And honestly, it's really amazing to have all of you here today. And I'm so honored that you're able to take out. I know how busy you are. Margaret is here from the event, how busy you all can be. And then you still made that time to come and join us for this community awareness. Thank you so very much. And any last words? Anybody else? I don't want to end and then somebody's like, oh, yeah. Well, anyway, we're going to be around. Yeah, I'm sure like 5 minutes will be here just chatting. I'm going to bring out the jollof rice now so we can at least take our food home. Yeah, we might not have time to, but I think the little ones are eating over there. But yeah, so we can have our lunch once we get home. Got jollof rice and fried rice for everybody. So thank you once again. And yes, it's been a pleasure, hosting this event. And we're going to have more. Dr. Tola, please clear your diary for us. I'll keep knocking and knocking. Yeah, because honestly, I want more people to hear. I'm glad that we have our men here because that was my worry. I want the men to come and hear about posture. Because we do all of our events, we have women. Last time we did another one, we had 50 women next door. But I was like, I want men. I'm glad Chidi and everybody has been to come out today. The men that are in our midst today. And Michael's big brother. Oh, it's Michael's big brother. Yeah, hello. Yeah, so I'm glad that, you've come out to listen to this. So please, next time, make sure you bring your friends, Chidi, your brothers. Everybody has to come and hear. And because, with awareness, that's what happens with awareness. You might think, oh, I just did this meeting or this session. But someday it will come in and you say, oh, yeah, the doctor said this, that lady said that. And then it will click. And then early detection, that's our preaching here. If you can catch it early, you can be here, even if it's late, but then you didn't delay any further. because it could have been late, but then you delayed more, But even if it's late, but the minute they said it is, go for your style of treatment. So all the early intervention is key. Let's keep telling our friends, cancer is not a death sentence. If you have any worry, any single thing to think it might be cancer, please go to the GP. So thank you once again, and then have a lovely, lovely rest of the afternoon, rest of the weekend. So so let's network, shake hands with everybody, make friends. What's it called? Your cards. Okay, group photo. Yes, of course. Let's do a big group picture, please. Yeah, that would be really good. And thank you to our media person, Major General, Major Adewumi Adisa. He's marvelous. And we're actually on YouTube live. He's put us on, so people that couldn't make it. People that couldn't make it have been able to key in. Have we got any viewers on YouTube? A lot. Wow, look at that. And make sure you have your name. What we finish, we have our names on the attendance. I think what the attendance, so we can so then you know the attendance from then try. Just kind of put your name on the list before you go, so that we can have your email address and for the record as well. So what do you want to, okay, so let's put the picture. Okay. So how do you want to do everybody be okay. So I was something. Okay. So that's happening. Can you all come there? Why do you do it this way? What do you think? Will it work? Since people are already there. Yeah? Okay, all right. That's a good idea. So let's do it this way. Please join in. Okay. Make sure you smile for the picture. Cancer free. Let's down on time. Cancer free. Amazing. Oh, thank you. Thank you so much. Thank you so much. Let me bring out it. Thank you for making this here. Thank you. Let me bring out our love.
One, two, 1, 2.